Good afternoon. Thank you for joining our Simon Says Expert Series today. My name is Kayla Hsu, and I'm the Community Outreach Manager for Rethink Tobacco Indiana. Like our speaker today, I'm a trained tobacco treatment specialist and have earned the National Certificate in Tobacco Treatment Practice, which is currently the highest level of recognition for tobacco treatment professionals. For the past 3 years, I've worked closely with today's speaker as she has served not only as my mentor in the field of tobacco treatment, but also as my supervisor as she provides leadership for Rethink Tobacco Indiana as a project director. Initially starting her career off as a respiratory therapist, Debbie Buckles quickly realized she wanted to positively impact her patients by helping them to quit tobacco. Debbie now has more than 25 years of experience in developing, implementing, and evaluating tobacco-related programs for healthcare professionals and consumers across the state of Indiana. Since its inception, Debbie has overseen the IU Simon Comprehensive Cancer Center's tobacco treatment program as the program director. Through this role, she provided guidance and system-level support to various clinics treating patients with cancer and provides tobacco treatment counseling services to patients enrolled in the program. Recently, Ms. Buckles has transitioned to the Cancer Center's Office of Community Outreach and Engagement as a subject matter expert on tobacco control. And with that, I will turn it over to our expert, Debbie Buckles, to present It's Never Too Late to Quit Using Tobacco, even after a cancer diagnosis.
Thank you, Kayla. I'd like to start by thanking you all for attending today, and I want to give a big thank you to Kayla as well, not only for that introduction, but for moderating for us today, and as well as helping me with many of the graphics today. She's an expert at that, by the way. So a big thank you, Kayla. I want to take just a moment and talk just a tiny bit about our team. We're a tiny team, but a mighty team of three tobacco treatment specialists in the Cancer Center. Kayla's work focuses on behavioral health and working with partners across the state to integrate tobacco treatment in those healthcare systems. But I'd also like to introduce you to another very important member of our team, and that's Danielle Barwise. Danielle is the tobacco treatment specialist that is the primary day-to-day provider of tobacco treatment services in the Simon Comprehensive Cancer Center. So if you haven't already seen her in the building or over in the infusion area, you may well soon, now that especially you know her face, so please say hi. I've had the opportunity to hear from a number of her patients about their experience with Danielle, and they absolutely love her. They've said things like, she's my rock. I've tried many times to quit and couldn't, but with her help, I was able to quit for good. And so I want to send a thank you to Danielle for all the support that she provides our patients as well. I'd also like to take just a second and let you know what a tobacco treatment specialist does. Kayla mentioned it just a little bit. But we are known as TTSs for short, and we are professionals who are specially trained to provide treatment for individuals who want to stop using tobacco products, all tobacco products. So we understand the science behind tobacco addiction, nicotine withdrawal, and effective treatments for tobacco dependence. The TTS develops individualized treatment plans using comprehensive strategies, evidence-based assessments, including FDA-approved medications, as well as cognitive behavioral strategies. And we're going to talk about some of these things here in just a few minutes. So I don't like to talk about the ain't it awfuls. So I have to today for just a little bit, but I've put just as little in here as possible to give you some background. But it's important to know that tobacco is firmly linked with at least 12 different kinds of cancers, which you see listed here on your screen. People often associate lung cancer with smoking, and there's a lot of stigma around that, but they may not think about other cancers that are related to tobacco use, for example, bladder cancer. So according to the Centers for Disease Control and the Surgeon General, 40% of all cancers diagnosed in the United States and 30% of all cancer deaths are caused by smoking. Tobacco use is related to cancers throughout the body, as we mentioned, and that's because when the tobacco smoke is inhaled, either through direct smoking, or secondhand smoke, all those toxins, about 7,000 chemicals, are inhaled and absorbed into the lungs, and then absorbed by the lungs into the bloodstream. And then those toxins are pumped throughout the entire body. And that includes about 69 that are known or suspected to cause cancer. So it's important for patients to understand that. And I think it's important for providers and clinicians to understand that as well. The one thing that the individual tobacco user wants, though, is nicotine. Nicotine is the addictive substance and the only addictive substance in all of the tobacco smoke. It doesn't cause the ill health effects other than the addiction. So you see a number of things listed here. Many of them you probably recognize. And so it's important to know that we want to provide treatment that will help reduce that nicotine addiction and eliminate exposure to all of these toxins. So as we've said, it's never too late, even after a cancer diagnosis, and especially before starting cancer treatment. We know many patients feel too stressed or too overwhelmed with their recent diagnosis and upcoming treatments, but we want patients to understand how important quitting is so that their treatments can be more effective. These treatments often have a number of unpleasant side effects, but quitting can help reduce those side effects, and it can help, as I said, the treatments work better. So it's important to encourage our patients to talk to someone about quitting or even cutting down before starting their treatments. Studies have shown that following surgery, continued smoking or tobacco use can result in quite a few complications, including from anesthesia, impaired wound healing, increased infection rates, and that's all due to those toxins that we showed you on that screen previously. But also during radiation, again, those toxins will reduce the effectiveness of the treatment and impact how well the body handles those treatments. And of course, chemotherapy is impacted by smoking, and we'll talk more specifically about this in the next two slides. But tobacco use weakens the immune system, and so does chemotherapy. In addition, tobacco reduces the blood flow, so the blood vessels are constricted, they're much smaller, which makes it harder for these medications or chemotherapy agents to be perfused through the body as needed. The bottom line for all of these treatments is toxicity and infection can result in having to stop treatments temporarily or result in reduced dosages, which again impacts the effectiveness of treatment. In this slide, we're showing you about specific chemotherapy agents, and several agents are specifically impacted by smoking. A 2007 study showed that one chemotherapy agent had almost an 18% faster clearance than in non-smokers. And this is important because if that chemotherapy is clearing the body faster, it's not in the body long enough to do the job it's meant to do. Two other chemotherapy agents have also been proven to be affected by smoking. And in fact, one manufacturer actually recommends using in caution with smokers. And since tobacco use, again, we talked about how it constricts the blood flow or blood vessels, it could impact many other chemotherapy agents. And so again, reducing how well it gets to the area of the body that it needs to do its job. So quitting prior to treatment is best. And we really want to urge all patients to quit as soon as possible. Numerous studies have examined the different influences on continued smoking on cancer outcomes. This study here looked at the side effects among 947 cancer patients during treatment and 6 months following treatment. Smokers were significantly more likely to report severe levels of these side effects, including concentration problems, skin problems, sleeping problems, weight loss, and depression during treatment, and that persisted for up to 6 months after treatment as well. In addition to these worsening side effects, smoking also resulted in more frequent toxicities. So I've seen this many times in patients where their kidney functions or their liver functions are decreased and they have to delay treatments, or maybe their blood counts are reduced so low that they have to postpone treatments. However, after they quit smoking, we see fewer of these problems. I'm not going to say they're completely eliminated, but we definitely see a difference. So the significant persistence of these side effects also reduces quality of life. And so that's another thing we really want to help patients understand. I have to take a minute and talk about COVID-19. I'm sure we're all tired of hearing about it, but it also has very impactful results in cancer patients and in all patients, especially those that are smoking. Again, because smoking suppresses the immune function and the immune system. And so making patients more susceptible to viruses and bacteria as well. And so a study in the Chinese Medical Journal looked at 78 patients with COVID-19 and found that those with a history of smoking were 14 times as likely to develop pneumonia. Now, some people have asked about vaping and COVID-19, so I want to touch on that just briefly. There isn't a lot of data, but we do know the risk of viral infections has not been studied much in those that vape, although there are some epidemiological studies suggesting that they are more likely to get respiratory infections. And then, of course, we know that cancer patients often experience suppressed immune systems. And then, of course, if they have a suppressed immune system from smoking and or vaping, this can be a double whammy, significantly reducing their immune system. Let's talk a little bit about survival. So 2 recent Surgeon General's reports have findings on smoking and cancer. The 2014 report states that continued smoking after a cancer diagnosis is associated with more death from all causes and cancer causes as well. And then, of course, there's always the risk of another cancer, so what we call a second primary cancer. So maybe the person was initially diagnosed with bladder cancer, but later on may be diagnosed with a different type of cancer, say, for instance, lung cancer. And the other issue is that the original cancer could come back, or what we say as recurrence. So, and then lastly, we have already mentioned this, but the report stated that continued smoking results in poorer responses to treatment because of those reasons we just talked about. But the good news is that in the 2020 report, they stated that quitting smoking had very positive effects, including increased survival of many different types of cancer, but especially among lung cancer patients. More good news. I think we're done with the ain't it awful. Let's go on to the good news. More good news is that when someone quits, there are immediate benefits in as little as just a few minutes, not just related to cancer, but overall physical benefits. So again, even as little as 20 minutes with positive changes to heart rate and blood pressure, all the way up to 15 years with a decrease in risk of heart disease. I think this is really important to really drive home that message that it's never too late to quit. Many, if not most, people already know about smoking and cancer and how bad it is and other health problems related to smoking, and they often feel ashamed and that it's too late to quit now. Clinicians need to be prepared to share what patients have to gain from quitting smoking. Oftentimes people feel like they're giving things up, they're giving up this and that. And we want them to know that actually there's a lot of positives to quitting, and they can regain a lot of health if they are able to quit successfully. For instance, we as clinicians could say things like, we have these treatments to offer you for your cancer, but we need your help for you to get the most benefit. Or maybe saying quitting smoking is the best thing you can do, and we can help when you're ready. There are many different forms of tobacco on the market today. The tobacco industry is not going away. While cigarettes do remain the most commonly used form, especially in adults, we are seeing people switching to other forms or even using multiple forms at the same time. So it's important that clinicians ask about all tobacco use, not just saying, do you smoke? And that's because we know that these tobacco products have many of the same toxins in them, maybe at different concentrations, but again, they can still have a significant impact on health. I know this is a complicated slide, but we're not going to go into it real heavily. It's just here to say that nicotine has a dramatic effect on the brain. Nicotine, again, is the addictive substance of all of those 7,000 compounds in the tobacco smoke. And when a person inhales tobacco, nicotine reaches the brain within 7 to 10 seconds, very quickly. And that then releases dopamine. And this is a feel-good drug, which really makes people feel like they want to continue to use nicotine. People like to feel good, right? And so nicotine stimulates the dopamine reward pathway, very similar to things like eating, drinking, and even engaging in sexual activity. Those are all things we need to do. And so those things are meant to trigger the dopamine reward pathway so that we as humans do those things that we have to do for survival. The sad thing is drugs such as amphetamines, cocaine, heroin, and of course nicotine also stimulate this reward pathway, reinforcing that behavior so it will be repeated. So when individuals ingest nicotine and these other drugs and they reach the brain, they also trigger that reward pathway and feel the same pleasurable feelings. So researchers do believe that with chronic drug use, the brain becomes chemically altered, transforming a drug user into a drug addict. And this is why it makes it very hard for people addicted to tobacco to quit. Okay, so now that we've learned a little bit about tobacco dependence, let's move into the treatment modalities. This slide is illustrating that tobacco dependence is a two-part problem. Actually, I like to say tobacco dependence is a complex issue. But as far as treatment goes, we really want to focus on treating two aspects of the addiction. People cope with many situations and emotions by smoking or using tobacco. So for people to be successful quitting, we need to address all of the aspects of the addiction. And here in this slide, in the next few slides, we're actually going to talk about the physical aspect of the addiction or the body's need for that nicotine. We treat that with the medications. And we're going to talk briefly about some of these medications, but these medications help ease the craving or the physical withdrawal so that the individual can focus on those behavioral aspects of the addiction without coming unglued. It has been well documented and well proven that the combination of medications and counseling are far more effective than either alone. And you'll see that here in this chart on the right-hand side of the slide where we're comparing different types of treatments. And you see that unaided or no help, and self-help range between 4 and 14%. But as you can see, counseling and medication does produce a 25 to 30% success rate. Now that doesn't sound like a lot, I know, because usually, an antibiotic or some other treatment has much higher success rates, but this is an addiction. And so it is a chronic relapsing disorder. Even recently, though, I've heard it said that cold turkey is best. Now, this data from the clinical practice guidelines shows us that's actually not true. We do know that medications and counseling are best. So how do medications work? How are they going to help us? Well, they are not a cure. It is not a magic bullet. But these medications, as I said a minute ago, will ease the physical withdrawal symptoms, which then allows the individual to focus on behavior change and coping mechanisms. And we know that these medications do significantly improve success rates. So what are these medicines? Well, currently there are 7 FDA-approved medications shown here on the slide. 5 of them contain nicotine and 2 of them do not. I don't have a lot of time today to go into each and every one of these 7 medications, so I'm just going to highlight a few. 3 of these medications on the left-hand side of your screen, the gum, the lozenge, and the patch, are all over the counter, so you can go to any drugstore and purchase them. However, if there is a prescription for them from a physician, or if you see your pharmacist, you could get any of these OTCs covered by insurance. So that's really important. A lot of people don't know that. And that helps obviously financially. So pharmacists in Indiana can provide all 7 of these medications without a prescription using what's called a standing order. So this is something new for Indiana. So I want people to know about it and be able to take advantage of this great resource. And pharmacists are able to help with doing some counseling and help with determining which medications might be best for the patient too. And again, that's a big issue. Which medicine do I use? Which one's the best? And that depends a lot on the individual, their health history, previous quit histories, what they've used, what they haven't, their daily schedules and routines. So there's a lot that goes into identifying which medication might be best. The most common reason people say these medicines don't work is because they either didn't use it right or they didn't have the right dose. A lot of people are underdosed with these medications, especially the nicotine replacement products. Now you see all of the ones, there's 5 there listed with nicotine in the name, and those are medications we call nicotine replacement therapy. It's because we're replacing the nicotine that they're used to getting from their tobacco products. What? A lot of people are going, wait, why would I take nicotine if I want to stop smoking or I want to stop using other tobacco? Well, the reason is, again, because a little bit of nicotine helps the person stay physically comfortable while they can adjust to this new lifestyle and using these new coping mechanisms. This amount of nicotine in these products is much lower and it's absorbed much slower. A colleague of ours in the field says, think of it as low and slow. So, and the addiction rate of these products is very, very, very low. So let's talk about some of the specific products here. We're going to start with talking about the nicotine gum. This is the first product that ever came on the market, and it's absorbed through the lining of the mouth. The most common mistake with this product is that patients chew it like regular chewing gum, and that's not going to work. What we need people to do is chew it until they start to taste it or get a tingling sensation, and then park it in their cheek. That's how the nicotine is absorbed into the body for this product. The other thing is, most people think they need to use it when they're having a craving, and that's not actually accurate. They need to take it about 30 minutes ahead of time. So it's best to use this on a schedule. The other important thing to note about the gum is that you can't eat or drink with the gum in your mouth, and you shouldn't drink or eat anything 15 minutes prior to using a piece of gum. The lozenge is very similar to the gum in the fact that it is also absorbed through the lining of the mouth like the gum. We also, with the gum, you don't want to chew it like regular chewing gum. And with the lozenge, you don't want to chew or swallow the lozenge. Again, parking it in the cheek, taking it out, moving it around to a different place, and parking it again is the best way to absorb the most nicotine. And again, this also takes about 30 minutes to feel the effect. So again, this is something we want to use on a regular schedule. And since it is absorbed through the mouth like the gum, we also don't want to eat or drink anything other than water 15 minutes prior. So the gum and the lozenge come in 2 and 4 milligrams. How do we know which one is best? The best way to know is how soon after waking the person uses tobacco or smokes. So if they smoke within 30 minutes of waking, they want to go with the higher 4 milligram dose. But if they can wait 30 minutes or more before having their first cigarette or using tobacco, they could go with the 2 milligram lozenge or gum. And now the patch, another very common product that's been around for a long, long time. Like the gum and the lozenge, The patch is over the counter as well. So again, you can go to any pharmacy and pick up any of these three: gum, lozenge, or patch. But again, if they get a prescription or see the pharmacist, they can get prescription drug coverage through the Affordable Care Act as a preventable service. The patch comes in 3 strengths: 21, 14, and 7. And again, this is absorbed not through the mouth, obviously, because you're putting the patch on your skin. So it's absorbed across the skin, and blood levels of nicotine are lower and fluctuate less with this patch than they would if somebody is smoking. So we, again, are delivering a steady state of nicotine. They're getting a constant amount of nicotine for 24 hours. And the patch can be used in combination with gum, lozenge, or nasal spray or inhaler as well. So it can be combined with other, and it can be prescribed with a couple of other medicines we'll talk about here shortly too. Patches are intended to be used in a stepped down manner over 24 hours. So you put one patch on, you leave it on for 24 hours, and you use that dosage based on if you're using Nicoderm, which is a brand name. If you use Nicoderm 21, you're going to leave that on for 6 weeks. And you would start with the 21 milligram patch if you're using 10 or more cigarettes per day. It would be recommended to start with the 21. There's also a generic version, and they recommend using, again, the 21 for 10 cigarettes a day or more, but they recommend for 4 weeks. And that's just a manufacturer's recommendation. And then you would step down to the 14 milligram for 2 weeks, and then the 7 milligram for 2 weeks. The most common problem I see with the patch is patients are feeling good, they're feeling confident, and they say, oh, I don't need that anymore. And then they stop using the patch 3 weeks, 4 weeks later, and guess what? They end up relapsing. So it is recommended to complete the full course of treatment with the patch. A couple other things real quickly about the patch is water does not harm the patch. So if you put it on correctly, you can then bathe, swim, shower, exercise, any of those things, and the patch should stay on. On occasion, we do have patients that say, it just won't stick. So what I tell patients is to just take and put the patch on and then take an ACE bandage and wrap it around. You want to make sure that the patch goes on between the neck and the waist. So it could be put around the waist, and the ACE bandage could be used, or around the arm. You want to make sure to apply the patch each and every day, leave it on for 24 hours, and remove the old patch and put a new patch on at the same time. Do not leave additional patches on. And don't use that same area again for 1 week. So if you put it here, don't put it here for another week. You can put it just below or on the inside of the arm, the other arm, but just not directly in the same spot for 1 week. Want to make sure to choose an area that's not hairy either. A good spot is always underneath the arm on the inside, because that skin is a little bit thicker or thinner and absorbs a little faster. Another thing important to remember about the patch is it takes 2 to 4 hours after you put the patch on for it to be at a therapeutic level. So don't expect it to work right away. Other common side effects are listed here, including mild itching or burning when you first put the patch on, and that is not abnormal. That's how you know the patch is actually working. Some people do experience vivid dreams and sometimes insomnia. So that, and in those situations, we would have the patient take the patch off if it's too disruptive, and then put it at bedtime, and then put one on again in the morning. But again, remember that when you do that, it's going to take another 2 to 4 hours for that patch to be at an effective level. So you might have to resort to using the patch, the gum or the lozenge in addition while that patch is kicking in. One of the other things about this patch is sometimes people do have redness and itching when they take the patch off for a day or so. And that also is not that uncommon. And we wouldn't want people to stop using the patch because of that. What we recommend is just using a little over-the-counter hydrocortisone cream. Now, one of the next medications is a prescription medicine, but it does not contain nicotine, and it's called Bupropion SR. This medication's been used for many, many years. A lot of people use it in the form of Wellbutrin for depression. And so we have a lot of experience, a lot of evidence, and a lot of science behind the medication. We don't know so much about using it in smoking. It's been around for quite a while for smoking, and it used to be on the market as Zyban when it was indicated for smoking cessation or to help with tobacco treatment. But the makers have removed Zyban from the market. It is the same exact medication as Wellbutrin, or in this case, the generic is Bupropion. And so it is very effective and was accidentally found to be helpful with helping people quit smoking. And that's because people using it for depression started saying, you know, I just don't like the way my tobacco tastes anymore. I just don't feel like I get as much pleasure from it. So they were quitting. The important thing to know about this medication is it must be started 1 to 2 weeks before the quit date. And that's unlike the nicotine replacement products, which you start on the day of your quit date. And some people do those on what we call a pre-quit or practice quit. The most important, or not most important, but one thing I want you to know are some of why this works. And it works to reduce cravings for nicotine. As I mentioned, sometimes even people say it changes the way their tobacco tastes, but it also helps alleviate some of the nicotine withdrawal symptoms as well. Some of the common side effects include insomnia. So if this were to happen, we would just ask people to take their second dose of the day earlier in the afternoon. And then dry mouth and nausea also are some common side effects. Again, we can adjust the dosage and that might help with some of those issues too. And then some more less common side effects are listed here for you as well. I think one of the important things to note about this medication is one of the disadvantages, and that's about the lowered risk for seizures. So if an individual is prone to seizures or has had seizures before, this would not be the medication for them. So a lot of people have heard about this medication, Chantix, or generic, or the, not the trade name, but the generic name is varenicline. There is a new generic that was just recently approved. It is only available by prescription. And again, this one also does not contain nicotine. This is also like Bupropion in that you want to start treatment 1 to 2 weeks before quitting. So it should be taken after eating a full meal and with a full glass of water too. And I'll talk about why in just a second. This medicine also does reduce symptoms of nicotine withdrawal. And it does that by blocking the dopamine reward cycle. You remember that from the brain picture I showed you earlier. And so it's important that people understand that this affects the brain and the chemistry in the brain. So it blocks that feel-good feeling. Patient education as far as varenicline or Chantix, as you may know it, very common side effect is nausea. However, that can be reduced and avoided completely with that full meal and a full glass of water with that dose of varenicline. We do have a few other side effects like insomnia, abnormal dreams, and headache. And again, adjusting the dose can help with some of those. And then, of course, a few more or less common side effects. I've honestly not seen these in my patients, other than the taste alteration. And again, people just say, it doesn't taste, my cigarettes don't taste as good. Again, all 7 of the medications should be covered by insurance and Medicaid. So these should have very little copays, if any at all. But the cost without insurance of varenicline can be a significant burden for patients. I want to talk just briefly about the warnings and precautions of bupropion and varenicline. A lot of people have heard about this, especially as it related to Chantix. But there were some neuropsychiatric symptoms and potential suicide risks, and some of these symptoms listed here. You may have already heard about this. In 2009, the FDA did require a black box warning on these medications for that risk, and included things like depression, suicidal thoughts, attempts, and completed suicides. But however, that black box warning was removed in 2016 because the FDA mandated a study looking at these neuropsych effects. And that study is this one pictured here. And that study found that, the study is called the EAGLES trial. EAGLES stands for a long drawn out name, which I won't bore you with. But this was a very, very well done study. It was multinational, randomized, double-blind research trial conducted at 140 centers in 16 countries across 5 continents. They had about just over 8,000 participants, and half of those had a psychiatric diagnosis and half did not. So they got a great representation in their participation. The important thing was that researchers found that the proportion of moderate or severe neuropsych adverse events did not differ significantly by treatment arm. So they looked at Bupropion, they looked at varenicline and patch. And if you see from the slide, it says that the risk of these mental health side effects is still present, especially in those currently being treated for mental illnesses such as depression, anxiety, or schizophrenia who have been treated for mental illness in the past. However, most people who had these side effects did not have serious consequences such as hospitalization. The result of the trial confirmed that the benefits of stopping smoking outweigh the risk of these medicines. It's a very important finding, and that's what led to the removal of the black box warning. I want to talk just real briefly about combination therapy. So we mentioned that earlier. So usually what happens is you combine a long-acting formulation like the patch with a short-acting formulation, gum, lozenge, inhaler, or nasal spray. And this delivers a much superior relief because you have the steady state of the patch providing nicotine, and then you can adjust the dosage with the short acting. Let's talk a little bit about that other component of tobacco dependence, the behavior aspect. So again, we talked about the physical side. Now we're going to talk about the behavioral. So cognitive behavioral therapy, behavior modification, coping skills training, relapse prevention, and management are all ways to treat the behavioral aspect. And tobacco treatment specialists are highly skilled in both medications and cognitive behavioral approaches. In addition, in a moment, we're going to talk about another resource. But so your 2 great resources we just mentioned have been the tobacco treatment specialist or the Indiana Tobacco Quit Line. The challenges of quitting are very common, and most people experience a lot of this. People often use tobacco or smoke in many different situations. And I want you to think about that for just a minute. You probably have either smoked yourself or know somebody that smoked or uses other tobacco. So think about some of those common situations where people like to use tobacco. Any of these look familiar? Most commonly, people smoke when they drink coffee, driving in the car, after meals, maybe drinking alcohol or with friends. So sometimes these behaviors have to change or be slightly altered when somebody's trying to quit. The average adult tobacco user will take about 20 to 30 puffs, or 20 to 30 puffs, or 20 to 30 cigarettes per day and about 10 puffs per cigarette. So that's 200 to 300 times a day that somebody's taking a hit off a cigarette. Can you think about any other things you do 200 or 300 times a day? Obviously, that behavior becomes very automated because things that you and I do 200 to 300 times a day are things like blink, breathe, swallow, and you never ever think about doing any of those things. And so smoking becomes very automated for individuals too. And this makes it harder for people to quit. But the cognitive behavioral strategies can really help people to disassociate these behaviors with tobacco use. Quitting requires people to not only change what they do, but how they think. And so that's an important part of counseling. So that's, again, why we really want people to get help in quitting. This is an addiction like any other addiction, and we don't expect cocaine users or other addicts to just quit on their own. They get professional help. And I think it's really important for tobacco users to also get support. Let's talk a little bit about other help that is available. So one of the resources that I've already mentioned is that there's the Small Mighty team in the IU Simon Comprehensive Cancer Center. We do have a tobacco treatment program. We are very fortunate to have this evidence-based program here. And the Cancer Center and IU Health believe in the importance of helping patients to quit tobacco. And they've joined together to provide this resource for our patients. At the present time, though, the program is only available for our cancer patients. Providers of the Cancer Center probably are familiar with how to refer using the Cerner pool, But if providers are unfamiliar and need help, please let us know. We're happy to help. Our contact information will be on the last slide. But this is a free program for all of our cancer patients. And it's very comprehensive, and we use all of the evidence-based practices that I've talked about today. Another resource is the Indiana Tobacco Quit Line, which you may be familiar with, and you can reach them by calling that number right here on the screen, 1-800-QUIT-NOW. There's a variety of services that they offer, as you can see listed here. They do provide some free medications, patch, gum, or lozenge. Right now they have a promotion where they're offering the combination therapy that we talked about, where you can get patch or gum, or patch and gum or lozenge. And they have a behavioral health enhancement. So if patients have a behavioral health disorder, they can get even more services. But this is a great resource. Again, it's free. You can do it over the phone. Providers can refer to the Quit Line. And then the Quit Line will call the patient, but patients could also call into the Quit Line on their own. One other important thing I think about the Quit Line is that it's available in over 170 different languages, and all the individuals that are quit coaches are very highly trained, like tobacco treatment specialists. So that, again, is a free resource in the state of Indiana. So I want to thank you for your time today. I appreciate you staying tough with me and hanging in here for the last 43 minutes. I have added our contact information here. If anybody has any questions after the event, please feel free to contact myself or Danielle. And with that, Kayla's going to help us to take some questions. I know some people submitted questions ahead of time, but you're welcome to submit questions here today as well.
Thanks so much, Debbie, for a great presentation. So one question we received, which is always a popular topic, is about e-cigarettes. So can e-cigarettes help people quit smoking?
So that is a very common question, and a lot of misconception around e-cigarettes. E-cigarettes, as you saw in today's presentation, are not an evidence-based, FDA-approved method for quitting smoking. However, many people think that is the case. Actually, e-cigarettes contain a lot of the same components as cigarette smoke. So it's not something we would want patients to switch to in order to help themselves with quitting smoking. It contains nicotine as well. Oftentimes, most of the time it does contain nicotine. So no, we would not recommend this as an aid to quit smoking.
Thank you. And what advice do you have for people who have recently quit and may still be struggling to stay tobacco-free?
Well, first and foremost, especially after today's presentation, I would encourage them to look at what they've been doing to help themselves. Are they using some of these evidence-based approaches? And if they're not, I would encourage them to reach out to a tobacco treatment specialist or call the Quit Line to get some additional resources if they're still struggling. Now, if they've been off tobacco for more than a couple of weeks, we certainly want them to go out and try some of the medications because the nicotine is through their body now within a week. So adding nicotine would not be a good idea, but I would strongly encourage them to look at some of their behaviors and changing some of their routines. And if they're still really struggling, again, reaching out to a tobacco treatment specialist or calling the quit line. That's a great question too.
Great, thank you. And adding to that, what would you say to someone who has tried all of the medications and feel that they haven't worked for them? What else should or could they do?
Again, medications are going to treat the physical aspect of the addiction, but not the behavioral. So my guess is if they're still struggling, they're probably not dealing with those cognitive behavioral aspects. So changing how they think and what they do. So again, I would encourage them to reach out to a provider, a tobacco treatment specialist, or the quit line for support there if they need it.
Great. We've had another question that's come in. What do you feel the implications are of the Kathy Griffin diagnosis for those who smoke and or have lung cancer?
I actually hadn't heard about that until just a day or two ago. And so, it's always impactful when somebody in the limelight or celebrity speaks out about a diagnosis like lung cancer. Actually, Kathy said that she had never been a smoker, but I'm sure that as she was an up and coming comedian, she was probably exposed to a lot of secondhand smoke in the nightclubs and where she was performing. So that could be a potential resource of where the lung cancer came from. But we also don't know what other secondhand exposure she might have had. There's also genetics and a lot of things play a role in there. But I really appreciate when people speak out about things like cancer and mental health, because I think it helps reduce the stigma, which is so very important. People that use tobacco started doing so when they were very, very young, and they really might not have known what they were really getting into. And these individuals are not bad people. They have an issue that we can help with, and that's what I want people to understand. So I hope this brings some awareness to lung cancer and treatment, but also I hope people are kind and compassionate and can really learn from Kathy's experience and other people's, and I hope this helps to reduce the stigma.
Yeah, good point that there are a lot of factors also involved with that, and really just showing compassion to people.
And I hope that maybe individuals that do smoke will talk to their physicians about maybe getting lung screening as well.
So on a little bit related to that topic, what would you say to someone who has a loved one or family member who's smoking and they want to try to encourage them to quit?
I was in this situation for a lot of years. Both my parents smoked and my first husband smoked, and it was really frustrating. You feel hopeless and helpless, but you have to understand that a lot of times the user feels that way too, especially if they've tried to quit multiple times. And that's very common. When people try to quit smoking, it doesn't happen the first time or the second time. And some research shows it can take up to 30 attempts before people are able to quit for good. And so I think that's important to remember, number one. And number two, I think just having heartfelt conversations with that loved one that uses tobacco. Hey, you're really important to me. I would really love to be a resource and a support for you if you would consider quitting. And just really having some good, compassionate conversation with why it's important for you. And then talking to them about what are some of their fears. What are some of their concerns about quitting? Have they tried to quit? And if so, would they consider trying it again? Would they consider getting help from a tobacco treatment specialist or the quit line? And I think, again, just starting with conversation, not being negative and beating them over the heads, but just coming from a place of compassion.
Great, thank you. And what would you say now that a lot of folks are returning back to school, college campuses are opening up? What do you think is the best evidence-based treatment to use with college-age students?
Actually, all of these interventions we've talked today about would be very effective for college age students too. Some of the cognitive behavioral approaches might vary a little bit. The medications probably would not. But the strategies with teenagers can vary a bit because their concerns are not about health. They're invincible at this age. They're not going to get sick from smoking, but they might have some more immediate health effects like a cough or maybe common allergies or asthma issues. But the cognitive behavioral strategies that work best for them are talking about cost and talking about addiction, because these individuals really don't like to know that something else is controlling them. They want to be in control. So again, coming from a place of compassion and asking them what their thoughts are about tobacco use, what their fears are, and then helping them in that way.
Great idea, great notes. And adding to the medications that you mentioned is, how does someone know which medicines work best for them, or how can they select those?
That's a very good question. A lot of people ask that one too. So there is no right or wrong answer, and there is no one best medication. So a lot of times it's trial and error. If they've used a medication before, they will know if they liked it or didn't like it. The important thing is to find out, what works best in your daily life. Do you need something you can use once a day, like slapping a patch on, and that's it? Or are you able to use a gum or lozenge a few times a day in addition to that patch? Or, sometimes people are like, you know what, I don't have time for anything in my day. And so the patch or maybe the non-nicotine medications would be better because it's kind of once or twice a day dosing. And then they don't have to think about it so much. It also has to do with their personal health history too. So there's a lot of factors that go into identifying which medication might work the best. But also, if you get started on one medication and that's just not working for you, you need to let your providers know, because there are other medicines. Again, we have 7 FDA approved medications, and a lot of this is trial and error. And that's sometimes why it takes people multiple attempts to be successful in quitting, is they have to find the right way for them. And that's no different with the medications. Right medication, the right dosage, all of that can really vary.
Good point. And for providers, how can they help patients to quit, for patients that might be afraid of weight gain when quitting smoking?
So some of the medications we talked about today do delay weight gain. So the bupropion and varenicline may delay weight gain. We also know that some of the nicotine replacements may as well. But the important thing to remember is the biggest benefit is to quitting smoking. A lot of people don't want to gain weight, but it does not have the same health effect as continued smoking. So the priority for clinicians would be, to help that person quit smoking. But we can also help with the weight gain by increasing activity and exercise, watching our diets. A lot of people miss that hand to mouth aspect of smoking or vaping. So one thing to do to help with that is, instead of just eating anything, making sure that you're eating maybe carrots, celery, cucumbers, things like that aren't going to add a lot of calories. Again, keeping in mind, what's the bigger priority? What has the biggest bang for the buck? And that's quitting smoking.
I have to agree with you. And so we've talked a lot about quitting smoking. What about for smokeless tobacco users? Can they also use some of those nicotine replacement therapies to help them quit?
They actually can. Now, these medications are not indicated for smokeless tobacco or any other tobacco products, but you still could use them. It's just that there hasn't been a lot of testing for use with these other tobacco products. But I have used them frequently with patients, and had great success. I think one of the best ones for smokeless tobacco users is the lozenge, because that is very similar to what they're used to doing, is putting something in their cheek and then letting it sit there. And then again, that replaces the nicotine they're used to getting through the smokeless tobacco.
Great, thanks for that.
Of course,
and I believe
behavioral component's real important there as well too. It's not just a medication. Sorry.
Good point. The 2 parts to quitting.
Mm-hmm.
And I believe our last question for today, how can someone who maybe isn't a healthcare provider help to prevent tobacco use or assist with smoking cessation? Maybe they work in IT for a healthcare organization, or maybe they don't work in healthcare at all.
That's a great question, actually. And I think it's, again, goes back to that if there's a particular loved one in their life that they want to help, having those heartfelt, compassionate conversations like we talked about earlier, and supporting that individual, let that person know, I'm here to help you. I want to have a conversation with you about this. I want you to let me know what I can do to help. Because a lot of times, those of us that have never smoked or individuals that maybe have never been around it, even, they don't know what to do, and everybody's different as far as what's helpful and what's not. So I think having a good open conversation with those they care about. As far as prevention, like with kids, like if you have kids or you have nieces, nephews, whatever, I think, again, having conversation and strong tobacco free rules, like we don't smoke in this house, we don't use any tobacco products in this house, and having conversation about why, having conversation about how the products are addictive, and the cost of the products as well. They're very, very costly. So again, just having good open conversation. And there are some websites you can go to for help on how to have those conversations as well. If anybody's interested, again, just send me an email. I'm happy to provide that information.
Thanks, Debbie. And thanks everyone for joining our Simon Says Expert series. I do want to remind everyone that this session is being recorded, and a link to the recording will be posted on the Cancer Center's website as well as on our Facebook page. Thank you so much.